Hello, I'm Hossein Borgai. On behalf of CME Outfitters, I would like to welcome you and thank you for joining us for today's educational activity entitled The Role of Antibody Drug Conjugates in Advanced Non-Small Cell Lung Cancer, Guidance for Today and the Path Forward. Today's activity is brought to you by CME Outfitters, an award-winning accredited provider of continuing education for clinicians worldwide. Today's CME CE activity is also eligible for ABIM MOC points, so make sure you engage in today's event, answer profiling questions, submit questions, and provide your feedback. Once you complete today's program, please be sure to provide your ABIM ID and birthday in the evaluation. CME Outfitters will submit your MOC points. You can also claim this activity as CME for MIPS improvement activity. So please make sure to participate and provide examples of how you will change your practice, and CMEO will send your confirmation of your participation, which you can submit to CMS. I am Hossein Borgai. I'm Chief of Thoracic Medical Oncology and a professor in the Department of Hematology Oncology at Fox Chase Cancer Center. And I'd like to introduce our faculty today. I am honored and very pleased to be joined by two of my close friends. Let me first welcome Dr. Enriqueta Felip. She's Section Chief of Medical Oncology and Department of Thoracic Oncology at Vall d'Hebron University in Barcelona, Spain. Keta, welcome, and thank you for joining us today.
Thank you. A pleasure. Thank you.
I would also like to introduce my colleague and friend, Dr. David Gerber. David is a professor of internal medicine and population and data sciences, University of Texas Southwest Medical Center, and associate director of clinical research at the Harold C. Simmons Comprehensive Cancer Center, UT Southwest, Dallas, Texas. David, welcome, and thank you for joining us.
Thanks for having me, Hoss.
So let's review the learning objectives. Our first learning objective is to apply molecular testing to identify predictive biomarkers for targeted therapy in advanced non-small cell lung cancer, an important area for all of us. Our second learning objective is to evaluate the rationale for emerging therapies in advanced or metastatic non-small cell lung cancer. And our final learning objective is to employ best practices to manage lung cancer during the COVID pandemic. Our first section today is on the important role of mutation testing in non-small cell lung cancer, particularly in patients with metastatic disease. To get started, let me get our audience involved here. You should be able to see an audience response question on the screen, and we are asking you to vote on the question that you see on your screen. Which one of the following genomic alterations are recommended for molecular testing in non-small cell lung cancer? Your options here are A, ALK, ALK, B, BRAF, C, EGFR, or D, all of the above. Excellent. So we have the majority of the participants voting for all of the above, which I think is the correct answer. Keta, let me come to you. Any comments about the answer?
No, yes, I agree. So now in patients with non-squamous histology and stage 4 disease, I think we need, before starting treatment, for sure, the analysis of EGFR mutation, ALK rearrangement, and also BRAF V600 mutations, because we have drugs approved in this situation in the first-line setting. We will comment later on.
Sure. And David, any comments about those members of the audience who selected single genes or alterations?
Yeah, so Hoss, I think this question is a great example of how far we've come in the last 10 to 15 years. There was a time when there were really only one or maybe two druggable kinase alterations in non-small cell lung cancer, and we could predict who was likely to have them based on age, ethnicity, gender, and smoking status. And those days are gone. These are three examples from an even larger group of potential targets. And I think we owe it to all of our patients with advanced non-small cell lung cancer to look for them, because if we find it, it can offer a treatment option that really changes their clinical course.
Yeah, and I think that is the point that has to be emphasized at every opportunity. Let's move on to another question, possibly a target that is going to be more actionable in the future. what is the observed rate of HER2 mutations in lung adenocarcinoma? Your answers here are A, 0, which basically means none, B, 2 to 4%, C, 8 to 10%, and D, excellent. Majority of participants actually chose the correct answer, 2 to 4%. David, quick comment about this?
Yeah, so, this is a rare genomic event in lung cancer, but when you add this with the other potential targets, we now know that maybe about a third of our patients have available targeted therapies. And depending on what type of molecular profiling you do, you don't have to remember all of the individual potential targets. If you use something like next generation sequencing, HER2 alterations will be captured, as will the others.
Agree. And again, a point that I think we're going to emphasize throughout the program, that a broad-based platform is probably best suited for the clinical practice. Now, Kida, let me come to you on this next slide here. How would you describe this complex series of tests and molecular subtypes that we have in non-small cell lung cancer? And also, if you don't mind, please comment on your approach to treating patients in your practice.
Yes, thank you. So at present, approximately 85% of lung cancers have non-small cell lung cancer histology, and we know now that this is a highly heterogeneous group. So we are mainly dividing in patients with adenocarcinoma histology. This represents 55% of all non-small cell lung cancer patients, 34% of squamous cell carcinoma, and 11% of other histologies. We all know that the majority of patients are diagnosed with advanced disease. And for patients with non-squamous histology, there is a need for testing because we know that there are 15% of the patients with EGFR mutations. Also, we have patients, 7% with ALK translocations. We have also patients with other molecular alterations. And this is important because in our practice, we need to test for EGFR, for ALK, for ROS, for BRAF V600, and for NTRK. This is in Europe because we have EMA-approved drugs in these 5 molecular alterations, but we have also very good strategies and also FDA-approved in patients with MET exon 14, red, and we have promising approaches for patients with HER2 mutations. So in our clinical practice, we test for these molecular alterations. We test also for PD-L1, but even if the patient has a PD-L1 high but has one of these molecular alterations, there is a need to treat this patient with a targeted agent. For the patients without these molecular alterations, immunotherapy has a clear role, but I insist that only for those patients with molecular alterations. This is something, I think the study published by Mark Chris and all the group was pioneered in 2014 because there was an analysis, as you know, of 10 molecular alterations in patients with lung adenocarcinoma. And the study shows that for those patients with a molecular alteration treated with targeted agent, the survival was longer. So there is a clear rationale to treat these patients with targeted agents. And as you can see in the slide, we have a lot of molecular alterations in lung cancer. The alterations are, in general, mutually exclusive. And we have a number of agents in patients with EGFR mutations, ALK, MET, ROS, RET, NTRK, and now HER2. So there is really a need for testing these alterations.
I agree. And again, this is the point that we would like to drive home today, hopefully. And also for those members of our audience here today that might not know an answer to a specific question, please be sure to stay with us. We will address all of these questions throughout the program. As we're speaking about molecular testing, we have our first question now. Do you, Kida, in your practice, use smoking history to decide whether somebody should be tested or not? The question that came in is that, there's a 32-year-old male never smoker who comes in with non-small cell lung cancer with metastases to the brain, and how do you decide what to do with that patient? Can you again briefly go over the scenario how you choose who to test and what your practice is like?
Yeah, we are doing tests in all patients with non-squamous histology, irrespective of the smoking history. And in fact, we recommend testing those patients with small cell lung cancer or squamous cell carcinoma if no smoking habit, but not using only a smoking habit to not test patients with non-squamous. We are testing all patients irrespective of the smoking habit.
Yeah. Kara, I'm going to ask you to speak up a little bit. You're a little bit away from your microphone, so that would be great. Thank you. David, let me go to you about the same issue and also ask you to comment on the NCCN guidelines that we have on our next slide here. Again, I think the point that we try to emphasize is that everybody, regardless of the smoking history, should be tested. Is that what you do in your practice also, David?
Well, Haas, I think all of us would say that in a perfect world, of course, right? If you have enough tissue and you have access to the tissue, yes, I'm going to perform the testing. But the reality is that there's a lot of times when we either struggle getting access to it because we might be a third opinion and it's not even clear where the biopsy tissue is, or it's insufficient tissue that's clear up front, or you submit it for testing and you find out 7 days later it's insufficient tissue. And I think that's the nuanced area where perhaps my pre-test probability may drive behavior. So if I have someone in their 30s who's a never smoker and I have insufficient tissue and I did a blood-based test and that was negative, maybe that's someone where upfront I'm going to try to get another biopsy. But if it's someone who's smoked 70 pack years and I don't have all of that information up front, I think that maybe I'm just going to take the likelihood that I'm going to find something that changes my management as being pretty low and not prioritize that and rather get them to another therapy. It doesn't mean that I'm never going to try to get that information. It's just a matter of how driven am I to try that get that information now. And I think the NCCN guidelines is just reminding us as time goes by how important these options are. Because remember, in a best case scenario, say high PD-L1 expression, combination immune checkpoint inhibitor plus chemotherapy, maybe the response rate is 60% in a clinical trial. But if you've got the right therapy for the right target, your response rate might be over 90%. And it might include an intracranial response rate that's at least that high. And so it would be a huge error of omission not to give these treatments to our patients. By recommending targeted therapy for these patients, we're not saying that they should never get chemotherapy or never get checkpoint inhibitor. It's just a matter of what can we do up front for this patient who might be symptomatic, who might be scared, and who might be at risk for clinical deterioration. I've also seen over time that with squamous histology, there's been broader recommendation for doing testing from the NCCN. And I think that's important because some of these targets do show up in squamous. And also know that the call of squamous versus non-squamous can be a judgment call on the order of a pathologist. And certainly if someone's been a never smoker, we're going to question that histology anyway.
Excellent points, David. Thank you. I think, again, the guidelines are there to guide us, and I think you have to use the clinical scenario. Hopefully, when we get to the section that we get to talk about the liquid biopsies, some of the issues with the tumor access that you mentioned, we can talk about it a little bit more, because I have a feeling that might be a little bit of a better way of handling some of the tissue issues that we are dealing with. Kara, we've talked about molecular testing a lot. What we realize is that there are a number of platforms. Can you talk a little bit about what we have on the slide here in terms of comparison of various assays and tell us what your take is on all of this? And again, how do you choose to test your patients?
Yeah, so it's true that we have discussed there is a growing number of targetable oncogenic subtypes in non-small cell lung cancer. And I think this supports the use of NGS at diagnosis and also in some patients at acquired resistance. So there are different types of tissue and blood-based assays available. We can see in this slide. But basically, there are two basic types of NGS assays. One, the amplicon-based assays, multiple PCRs. But we have to recognize that in some of these methods, there is no reliable detection of fusions or copy number alterations. And we have the capture panels use hybridization that includes, yes, mutations, deletion, copy number alterations, and rearrangements, but the turnaround time is often longer. I'm working in Europe, in Spain, and I have to say that in our patients, we are doing first the analysis for EGFR, ALK, ROS, BRAF, and PD-L1, and for the patients that are negative for EGFR, ALK, ROS, and BRAF, these are the patients that we are testing for in NGS, but we recognize that NGS is the way to go even in our countries.
Yeah. And on the next slide, I think we have some recommendations from ESMO as well.
Yeah, this is important. I think it's an important paper for all European countries. So, in fact, in this paper, ESMO recommends using tumor NGS in patients with advanced non-squamous histology. And also, there is the mention that there is a high concordance with liquid biopsy. So, there is a need of both NGS in tumor and also NGS in liquid biopsy. And even in the paper, there is a list of genomic alterations with a level 1 recommendations according to SCAT in advanced non-squamous. So level 1 represent a target suitable for routine use and recommended a specific drug when specific molecular alteration is detected. And according to this paper, the level 1 recommendations in non-squamous histology is for EGFR mutation, ALK rearrangement, MET exon 14, BRAF V600, ROS, NTRK, and we have also red in the list, and HER2 with a level 2. So I think these are important recommendations for the future.
Yeah, that's interesting. I think the practice in the US is somewhat fragmented. I think many of the academic centers have their own in-house NGS testing platform, and those who don't use one of the sort of other established central testing laboratories that provide that kind of a service. I think the push in the US has been to do a little bit more broad-based platform because we've gotten to a point where we have 7 FDA-approved drugs in the US, and therefore, if you want to do one-off testing, you might actually have a delay in initiating the appropriate treatment. So the push here has been a little bit more towards trying to get a comprehensive test done, realizing that sometimes in the US we have to do a couple of different tests because some of the fusions might not necessarily show when you do a mutational analysis. And therefore that has added to the complexity of everything we're doing. So now we're talking about DNA-based assays, RNA-based assays, and so on. So definitely a little bit more complex. David, in the next couple of slides, we discussed the issue with liquid biopsies, which again, I have to admit, I'm sort of I would say late comer to the liquid biopsy. I am more and more convinced with the data that I see that the testing can be helpful, especially when there is inadequate tissue. But I was wondering if you can provide us with your thoughts about the comparison between tissue and blood-based assays and how you see the data and what you do in your practice.
Well, you know, Haas, I think the first thing that I'd say is that the ability to do a plasma-based assay, whether you term that circulating tumor DNA or cell-free DNA, is really a medical technical breakthrough. And so often in oncology, we're focused on therapies as breakthroughs, but I think diagnostic procedures can also be breakthroughs. And we've tried for really decades to analyze circulating tumor cells in a disease like lung cancer and have not been successful. And even in cancers where we are successful, like colorectal or breast cancer or prostate, it's actually not that helpful. And so to be able to pull out circulating DNA from a patient's blood and make a call about what's an alteration in the tumor is remarkable. You know, this technology was first applied to pregnant women who are interested in being tested for high-risk conditions such as Down syndrome. We used to have to do an amniocentesis, but it turns out that in a pregnant woman, 12% of the circulating DNA is from the fetus. So you isolate that and you can decide what's going on genetically. Well, in a patient with metastatic cancer, the proportion of DNA in the blood that's from the tumor might be 1%. And so that's even more technically challenging. And the reality is that a plasma-based assay is going to be less sensitive than a tumor-based assay. However, if it's positive, it is not a false positive. And we know that the response rate to a targeted therapy, if you're tissue positive and plasma negative, is the same as the response rate if you're plasma positive and tissue negative. What might be a reason why a blood-based assay would be positive and tissue negative? Well, it's thought that if you do capture DNA from a tumor in the plasma, that might be more representative or more heterogeneous than a single biopsy from a needle that might capture one portion of a tumor versus not another area. When do I, in my practice, use the blood test most often? In someone where I've been giving them a targeted therapy and they've developed resistance. I can tell them at that point, stay on the targeted therapy because I want them on the targeted therapy at the time that I'm testing the tumor, because that's going to drive the evolution of molecular pressure to yield a resistance alteration. And at that point, I'm going to be able to do a blood test without any interruption in their therapy. If that's not informative at that point, I might think about tissue. I tend not to get plasma and blood at the same time in everyone. I think that tends to be a lot of resources that are used, and we all know that the healthcare system is already almost going broke.
I think you mean tissue and blood. I understand what you mean, though. And I think those are very good points. So we're going to try to move a little bit more quickly now because, we don't have a lot of time, but we have a lot of material to cover right now. So, Kira, I'm going to come back to you now. We've talked a lot about testing. Hopefully, we've conveyed the information that testing is important, and it is something that could have a huge impact on how a patient is treated and the eventual care that the patient goes through. So, if we go and talk about targeted therapies, we're going to use the EGFR pathway and the EGFR family here as an example. So, Kira, if you can walk us a little bit through this cascade of events and signaling pathways through the EGFR, and again, talking about HER2 at the same time because they're part of the same family. But let's do this in a quick and concise manner so we can get to the rest of our program.
No, yes. So EGFR mutation was discovered in 2004, and we know that now we have first generation, second generation, third generation EGFR TKIs that are active and change the life in our patients. But there is another tyrosine kinase of the same family that is HER2, and we have seen in the first question that approximately 2 to 4% of lung adenocarcinomas have this mutation, and this mutation is also an oncogenic driver alteration. So we have some discussion about what are the molecular alterations that are suitable for treatment in the HER2. So we know that HER2 protein overexpression is present in 12 to 20% of lung adenocarcinomas, immunohistochemistry 2+ or 3+, but there are also HER2 amplification in patients with lung cancer in approximately 3% of patients at diagnosis and around 10% of cases in patients with EGFR mutations and acquired resistance. And we have discussed we have 2 to 4% of HER2 mutations. So the question now is, which are the patients that are suitable for treatment with anti-HER2 therapies, patients with lung cancer?
Great. So, yeah, I think HER2 is a new player for us, but in the world of breast cancer, this has been targeted for quite a number of years, as we're all familiar with that. But I think identifying who the actual patients are who might benefit from HER2-directed therapy in lung has been a little bit more difficult. But because of what you just said, that not only we have mutations, but also overexpression or expression and amplification, I think HER2 might be a relevant treatment option for using antibody-drug conjugates, the topic of today's discussion. So ADCs are increasingly being used in a number of different malignancies. A couple of them are approved for hematologic malignancies. And also in breast cancer, we have the use of trastuzumab, emtansine, and trastuzumab deruxtecan exatecan that was recently approved. So in order to discuss ADCs a little bit more, I partnered with CME Outfitters to develop an animation on the targeting and potential mechanism of action of ADCs. I hope you find the animation useful. I encourage you to use it in your practice and also for teaching. So together, let's look at the animation now. Here we see an antibody-drug conjugate approaching a few malignant cells, depicted here among a group of healthy cells. Cancer cells appear darker, and the cell in the center has the antigen on the cell surface. The cascade of events is initiated when the Fc fragments of the antibody in the ADC interacts with the antigen. The ADC consists of the antigen-specific antibody, preferably a humanized monoclonal antibody, which provides a high therapeutic index with low immunogenicity. The cytotoxic payload is connected via a linker, which is stable in circulation but can be hydrolyzed upon internalization. There are two types of linkers found on ADCs, the cleavable and non-cleavable linkers. Cleavable linkers can release the payload both intracellularly and extracellularly, whereas non-cleavable linkers are designed to be released intracellularly. Several cytotoxic payload molecules can be linked to a single ADC characterized by the drug-antibody ratio, which refers to the average drug-to-antibody ratio for a given ADC. Next, the antigen-bound ADC enters the cell via receptor-mediated endocytosis and is incorporated into endosomal vesicles. The antigen-ADC complex is processed in the endosomal lysosomal pathway, and the ADC, including the linker, is degraded in the acidic and proteolytic-rich environment, releasing the cytotoxic agents into the intracellular environment. The release of cytotoxic agents to the intracellular environment induces cell death, visualized here as the cells getting darker. Cytotoxic agents can also diffuse to adjacent cancer cells, causing cell death, which is known as the bystander effect or bystander killing. The linker chemistry needs to be optimized to retain a sufficient load of cytotoxic payload in the targeted cell while allowing some of the payload to diffuse if the bystander effect is desired. Great. David, I'm going to come to you now and ask you to elaborate a little bit more on the ADCs, to walk us quickly through some of the mechanism of action and some of the potential issues associated with these class of drugs.
So, Haas, I think the first thing that I'd say is that this is a long time in coming. Just as we've tried for decades to harness the immune system in our attack against cancer, yet checkpoint inhibitors didn't emerge until the last decade, we've been trying to target the delivery of cytotoxic therapy to cancer also for decades. Earlier on, we were a little bit more successful with toxin payloads like gemtuzumab for AML, or radioisotope payloads like ipilimumab for treating refractory non-Hodgkin's lymphoma. But it's really the technical developments recently that have allowed us to attach a cytotoxic payload, basically a chemotherapy drug, to a monoclonal antibody, which is about the most specific type of therapy in all of clinical medicine, allowing us to deliver that to a cancer cell to achieve higher levels there, but lower levels in terms of normal tissues and organs. That's what I think makes it so important. I think with this characteristic, ADCs actually extend the therapeutic window. So because more of the drug that you're administering to a person is going to the cancer than if you're just giving a naked chemotherapy drug that's not attached to an antibody, you can decrease the minimum effective dose. You actually have to give less of it to the person. And because you have fewer drug molecules going to normal tissues, normal organs, you're actually increasing the maximum tolerated dose, ideally making these drugs both more efficacious and less toxic than they would be if they weren't attached to an antibody. There are a number of characteristics that impact the efficacy and toxicity. And I think the most important one is tumor characteristics. And this is really the characteristic of your target. So let's think about a target like EGFR. Why are we not hearing about EGFR targeted antibody drug conjugates? Because EGFR is present on normal epithelial tissues like your cornea and your skin and your GI tract. And when you give a cytotoxic agent that's conjugated to EGFR antibody, people's vision gets worse and they get refractory diarrhea. So you want to have that target highly expressed on the tumor, but not on healthy tissues. You also don't want that target to be shed from the cancer into the circulation, because that can also lead to toxicity. And you want to be able to have that target internalized once the antibody binds to it, because its efficacy is going to be intracellular at the tumor DNA level. What about the antibody drug conjugate itself? You want the antibody to have high affinity to the target antigen, but you need that linker to be stable. While that antibody's getting there, if it releases the chemotherapy drug on the way, that's going to cause toxicity and decrease efficacy, and you want the drug to be highly potent. These were all the developments that took decades for us to get antibody drug conjugates to the point that they're FDA approved in diseases like lymphoma and breast cancer, and they're now looking promising in diseases like lung cancer.
Great. Yeah, I mean, the promise is definitely there, but as you pointed out, unfortunately, sometimes can be toxicity. So I'm going to stay with you for our next discussion also. So this is a case, a real-world scenario, how an investigational ADC used to treat relapse and refractory small cell lung cancer in patients after platinum etoposide and topotecan in this case, and what can happen when you use these antibody drug conjugates. So can you walk us through this case, please?
Yeah, so Haas, I think as you know, the anti-DLL3 or delta-like ligand 3 antibody drug conjugates were very promising in small cell lung cancer. Lots of patients who expressed this target in their tumor, which is about 2/3 of patients in general, had benefit. But it turns out that delta-like ligand 3 also has expression at pleural and pericardial surfaces. And so if we go to the next slide, you're going to see both simultaneous efficacy and toxicity. So on the left side of the slide, you'll see over the course of the first 3 months, 4 months of treatment, that primary tumor that's being treated as third-line therapy is really shrinking. That's formally a partial response. But after that, even after I'm no longer actively giving the drug, just take a look at these developing loculated pleural effusions and also pericardial effusions, lasting for months after the last dose of therapy, making this patient pretty clinically sick, despite the fact that she had a great response to therapy.
Yeah, so we have a couple of questions now from our audience. One is, can you differentiate between short-term and long-term toxicities of ADCs? And the second is, it's a little bit more specific. I'm not aware of any data differentiating efficacy by race or gender when it comes to ADCs, at least in lung cancer. And also, I'm not completely aware of data, if we have any data on patients who are of childbearing age, if that changes the dynamics of using an ADC. So I realize that 2 or 3 questions built in together. But I was wondering if you can comment about at least the short and long-term toxicity question.
Yeah, so look, I'm not a pharmacologist, but the circulating half-life of a chemotherapy drug is on the order of a couple of days. The circulating half-life of a monoclonal antibody could actually be a couple of months. And so I think these drugs do stay in the body longer. And I think when they get to target tissues, especially if that's a normal tissue, they may stay in that microenvironment for several weeks. We also have to remember that there's just some toxicities of targeted of chemo drugs that can be long-standing. Take, for example, peripheral neuropathy from chemo drugs. You could stop giving that drug and you're still going to have that toxicity months later in some cases if you're not careful. So if you've got an antibody drug conjugate that's got that as a potential toxicity, you're in trouble. Now, if you have an antibody drug conjugate where you happen to get some cytopenias, that might be a little bit less likely to last as long. Yeah. As for people of childbearing age, while antibodies themselves may not be teratogenic, and it's really going to depend on what the target is, we may not know, cytotoxic chemotherapy may be, and that's what these drugs are, right? These antibody drug conjugates, they're giving cytotoxic agents that are basically tubulin targeting drugs, similar in mechanism to taxanes. Yeah. There's some that are also conjugated to anthracyclines as well. There may be some literature in some cases that you can give those types of therapies to people of childbearing age, but for the most part, as a lung cancer expert, I'm seeing elderly individuals.
True. Yeah. So I think on the next slide, what we have is a select number of ADCs in lung cancer and other solid tumors that can be considered under development. As you can see, this is not even a complete list. This is basically a partial list. So these drugs are definitely of great interest in a clinical trial setting. Kira, let me now ask you to concentrate on some of the more promising ADCs based on limited data that we have right now that specifically target genomic alterations in non-small cell lung cancer. How significant do you think these trials are in lung cancer? And if you can briefly comment about where do you think we're going to go with them, how we're going to be using them?
Yeah, so we have studies with TDM1 in HER2 mutated patients. This is important because we discussed this is a molecular alteration that we have seen in 2 to 4% of the cases, but until now there is no clear standard of care. We have trastuzumab deruxtecan also analyzed in patients with HER2 mutations in a phase 1, and also there is data that we will present later on, phase 2. We have another important ADC, patritumab deruxtecan. This is an anti-HER3, so the important information was presented during the ESMO meeting in patients with EGFR mutation and progression. This is a HER2 target. And we have also agents targeting c-MET and TROP2. So these are, as far as I know, the most important studies analyzing ABC in patients with non-small cell lung cancer.
Great, yeah. So David, going back to you again. So we know that there's some data with an ADC called trastuzumab DM1. It's really one of the first ones to be used for targeting HER2 in non-small cell lung cancer. Again, we have some data from the trial. Again, I was wondering if you can walk us through this data a little bit and put it in context.
Sure. So I think the point to make from this slide is the enrollment biomarker, right? So here the patients aren't being selected because their tumor has a HER2 mutation. If someone has a HER2 mutation, maybe that's the population where I want to use just by itself a HER2 inhibitor like lapatinib. But here we're really using HER2 not necessarily because of its targeting function within the cancer cell, but because itself can serve as a target. Here, HER2 is functioning the way CD20 functions in non-Hodgkin's lymphoma. CD20 isn't a kinase molecule generating intracellular signals. It's just something present, allowing us to target an antibody like rituximab or an antibody drug conjugate. And I think that's what HER2 is doing here. So if you go on to the next slide, I do think that you see that there may be some correlation between efficacy and the degree of expression of HER2 in the tumor sample. And I do think that immunohistochemistry is actually a little bit more complicated in defining a target than, say, next-generation sequencing is. Because oftentimes with next-generation sequencing, the call on whether a mutation is present or not is really binary. But here we're characterizing a protein sometimes based on the prevalence of expression among cancer cells, but also the intensity of staining. And it may differ from one lab to another, but at least here what we're seeing is a higher efficacy in the highest expression by staining intensity of HER2.
Yeah, I agree. And I think there's added complexity because we know that HER2 is a target also in GI malignancies, particularly gastric. And there is a little bit of a difference in defining IHC positivity if you use a breast cancer criteria and a gastric cancer criteria. So that adds a little bit to the complexity, and it has to do with the way studies that are being conducted with these drugs actually define the IHC. So I think that is another point for us to concentrate on. Kira, on this next slide, we are looking at the trial data, but this one, as shown on the title, is focusing on HER2 mutation rather than expression. What do you think about this?
Yeah, this study is analyzing T-DM1 and ADC in patients with HER2 mutations. And yes, the study includes a limited number of patients, only 18 patients. The drug is well tolerated, but when we analyze the results in the next slide, we can see that this is really an active agent in these patients with HER2 mutation. So the response rate with T-DM1 is 44%, and the disease control rate more than 80% of the patients, and the progression-free survival is 5 months. So I think we have seen in this trial that yes, this agent and ABC is active with HER2 mutations.
Yeah, definitely. I think this is an interesting point to keep our eyes on. Again, we have HER2 mutations, we have IHC expression and overexpression perhaps. So you got to look at the trial data to see if they can separate these patients for you on the study. So on our next slide, David, this is basically an update to the previous trial where we have now both HER2 mutation and HER2 amplification. Now, from a clinical point of view, how significant do you think this is right now?
So, look, I think that if you have this therapy available for a patient, it offers them benefit. We're probably not going to see a tail on the curve the way we do with some patients who get checkpoint inhibitor therapy. We've just really never seen that with cytotoxic therapy. And we have to remember that ADCs are cytotoxic therapy. I think, a PR at 30% shrinkage or greater, that's really an artificial basis we use in clinical trials. Just look at this waterfall plot. The majority of patients are clearly having tumor shrinkage, and that's what we want to offer our patients. What about the PFS of 5 months? Why is it not as good as it is in breast cancer? My thought is that it really doesn't have to do with the target. It just has to do with how good are cytotoxic therapies in lung cancer versus breast cancer. We know going back decades that more people with breast cancer respond to chemo and respond to chemo more profoundly and for longer than is the case for lung cancer, right? I mean, that's just an old problem we have, and we're still going to face that to some extent with antibody drug conjugates.
I think that's a great point. It is definitely something to pay attention to going forward. Kira, we have another antibody drug conjugate, another promising agent, trastuzumab deruxtecan, or simply called TDXD. And here is some data that have been generated. I'm wondering if the next 2 or 3 slides you can walk us through this trial and give us your impressions about what we're seeing so far.
Yes, so we have this agent that you mentioned, trastuzumab deruxtecan, and this agent has been analyzed in patients with HER2 alterations in breast and also GI, but also patients with lung cancer. So we have the phase 1 trial, including non-breast, non-gastric tumors with immunohistochemistry positive. And there are 18 patients with non-small cell lung cancer included, 11 of them with HER2 mutations. So the authors show us that the most common HER2 mutation is the insertion, but again, very good responses with this agent. So the response rate in the all 18 patients included is 55%, but for those 11 patients with HER2 mutations with trastuzumab deruxtecan, the response rate is 72%, and here we can see a median progression-free survival of 11 months. So really promising results in this molecular alteration.
Yeah, next slide shows the Destiny Lung trial. I guess the question for both of you, and the data here might not be clear. This comes from one of our participants. Do we know if the patients who are HER2 mutant positive who are responding to these drugs also have IHC positivity or not? I don't remember seeing that level of data for this yet. Have you seen anything, Keda?
Yes, there are an analysis according to the immunohistochemistry expression of HER2, but in the publication there are responses in patients with immunohistochemistry 1+, immunohistochemistry 2+, and also immunohistochemistry unknown. And the conclusion from this phase 1 is that those patients with HER2 mutations have more profound shrinkage of the disease, irrespective of the immunohistochemistry status.
Okay. So what about this Destiny trial that we're showing here? This is, again, the trial with trastuzumab, the Toxicity that we were just talking about. Can you comment a little bit about the safety and efficacy data?
Yes, this was presented at ASCO, and I think it was an important presentation. I was able to participate in this trial. So there are two cohorts, one cohort of patients with HER2 mutations, 42 patients, and there is a cohort of patients with immunohistochemistry positivity, and we don't have the results yet from this cohort. So in these patients that were heavily pretreated, we can see that the serious adverse events were seen in approximately 52% of the patients, but no death was seen as a result of an adverse event. So again, very impressive response in these 42 patients with HER2 mutations previously treated. Response rate was 62%, and the median progression-free survival was 14 months. So I think
so again, yeah, you have first-hand experience with this agent, so tolerability does not seem to be a major issue, although there is a toxic side effect that we have talked about when we get to it, and it also does appear to be a fairly effective drug, at least based on early results. David, any thoughts?
No, Haas, I agree with everything that's been said. You know, the question about biology between a kinase alteration and protein expression in that cancer cell is such an important one. It really is. And, you know, I think about ALK lung cancer, right? So ALK is a gene rearrangement, but we also know that those tumors that harbor an ALK gene rearrangement are also those that are ALK positive by IHC. So I do think for many molecular targets, there probably is a relationship between those two phenomena that allow us to think about using ADCs in a population where we're also thinking about using a molecular targeted therapy. The only other thing that I would say about all of these slides that we're looking at is we should all remember, us as speakers and the listening audience, that the line at top that says any adverse event 100% isn't telling us that 100% of patients are having toxicity from study drug. It's just letting us know that over the course of their treatment, something has happened that is an adverse event. Maybe they tripped on the sidewalk, or maybe they bumped their head in the shower. That's what's being reported here. And so it's not that these drugs are particularly toxic.
Yeah, I do want to point out that, yes, I agree. And based on everything we've seen, the drugs are very safe. But with this particular drug, we do know that there is a slight chance of pneumonitis, and I think that is something that we have to pay attention to. So, David, we're talking about HER2, and we've talked about the EGFR and targeted therapies in general, but we know that her family has more members, in particular HER3, and there is another antibody drug conjugate targeting HER3. And I was wondering if you would walk us through that data and talk a little bit about HER3.
Yeah, so let's talk first about the biology of HER3. So HER3 is another member of the HER or EGFR family, and it dimerizes with HER2. It has ligands of neuregulin and herregulin. You guys can all see on the figure. And there's data going back actually over a decade in a disease like colorectal cancer that neuregulin or herregulin expression in tumors predicts resistance to EGFR targeted therapies. So clearly there's a lot of crosstalk between all of these. The real question I have about HER3 when it comes to antibody drug conjugates isn't so much its function, but its presence. And we know that about 85% of non-small cell lung cancer expresses HER3. And so I think that makes it a reasonable therapeutic target to consider in this disease.
Yeah. So on the next slide, we have a trial with a HER3 targeting ADC called patritumab deruxtecan. This was an interesting study. This was in patients who have been on EGFR-directed TKIs and chemotherapy. What are your comments about this one?
Yeah, so I just want to talk about that second row in the table, and it shows cytopenias. So cytopenias are a side effect of cytotoxic chemotherapy. And so we actually see these types of toxicities in a lot of antibody drug conjugate clinical trials. And it may not reflect the fact that the target of the antibody is expressed in bone marrow. It may more likely reflect the fact that these drugs are still not perfect, right? We're still seeing some unconjugation, right? The linker separating from the payload. So you do wind up getting some nausea and vomiting, maybe some hair loss, and maybe some bone marrow suppression because that toxic payload some of it is still going free in the circulation.
Good. On the next slide, again, we have some data about the efficacy. I know it's early, and I know we don't have a lot of data. We're talking about 56 patients. Any first impressions?
Yeah. So, I mean, the fact is that there's so many mechanisms of resistance to antibody drug conjugates, some of which may be target specific, and some of which may not be. We know that there are drug efflux pumps that may develop over time. So even if you do get the antibody drug conjugate internalized, you're pumping out that taxane-like payload into the circulation. So I think it's very, very early to really have an understanding of what are going to be the resistance mechanisms for a particular target or even for a particular cytotoxic payload.
Excellent. Now, I'm going to go back to what we were talking about HER2 for a moment because we just got a question about it. And that was, and I'm going to give my impression, and both you and Keta can chime in. And the question simply is, how do you explain having a drug uptake when there's HER2 mutation but not IHC? And I think this is the point that at least you and I, David, were talking before the program. How do you explain this? I don't have a clear explanation for what we are observing with this drug at this point. Any comments with that?
I do. So when a cancer shrinks, we don't actually know the mechanism of efficacy in that patient. So is the reason that antibody drug conjugate had effect because a cytotoxic agent was delivered intracellularly? Or let's think about the use of cetuximab in EGFR mutant non-small cell lung cancer, right? That's been studied for a long time, either as monotherapy or in combination with EGFR inhibitors. And there's no cytotoxic agent attached to it, and yet there's probably some efficacy. So I think in these cases where there's really high dependence on the HER2 molecule for signaling purposes, even if there's not a lot of it on the cell surface, I suspect that the antibody drug conjugate may be conveying efficacy solely because of the antibody in some cases, not to mention the drug conjugate, if that makes sense.
I guess the real question is, what's the role of HER2 mutation? What is it about the mutation that allows the drug to function? But I think that's something that probably we need a little bit more studies on before we can answer the question accurately.
Yeah, I mean, to do that, I'd be interested in, doing a window of opportunity pre-op study and then doing intratumoral PK. Right. Yeah. And that's really hard to do.
Yeah. So, Keta, we're going to go to other targets. Another very interesting target in lung cancer is c-Met. We've heard a lot about this. There are now a couple of different TKIs that are approved for targeting, again, c-Met. And again, This is another one of these targets that you can sort of identify the target through a number of different mechanisms. But can you comment on this pathway a little bit, and also about the potential role of an ADC?
c-Met is a hepatocyte growth factor receptor, so it's true that we have drugs now approved, Camontinib, but in patients with MET exon 14 skipping mutations. But we have other molecular alterations in MET in a similar way of what happened in patients with HER2. So we have MET amplification, we have MET overexpression, and until now we don't have any drug approved for patients with MET overexpression, for example. So perhaps there is a rationale to analyze also ADC in patients with MET expression. So we have one drug in the next slide that has been analyzed in patients with non-small cell lung cancer and solid tumors. We see MET overexpression, immunohistochemistry, or amplification. This is an ADC, telisotuzumab vedotin. And again, when we analyze the toxicity, we have seen that there are a number of patients with toxicity. There are 22% of the patients that stop treatment due to adverse events. But again, this agent seems active in patients with MET expression. If I can have the next slide, please. So only 16 patients were included, and again, with this difficulty of what is MET positivity, but the response rate with this agent was 18.8%. So at present, there are studies analyzing this agent in patients with lung cancer, and perhaps this could be important also for those patients with EGFR mutation and MET as a mechanism of acquired resistance.
Interesting. So you bring up a couple of good points. Again, emphasizing that you can define MET alterations in a number of different ways in lung cancer. This particular ADC is targeting the pathway. And again, I agree, given the smaller numbers, it's a little bit hard to know where exactly we're going, but so far promising. And again, the intersection between EGFR and developing resistance to targeted therapies in EGFR with TKIs and emergence of MET as a potential mechanism of resistance is an important one that I think needs to be explored. So good points there. Thank you for bringing that up. We're going to move on to another target. David, this one is another interesting one, trophoblast cell surface antigen 2, or TROP2. And again, we have a slide showing the target. I was wondering if you can walk us through this one too.
Yeah, so again, the question is, what is its biologic function, and then what is its prevalence in the disease? And I really want to focus on the second question. We do know that in non-small cell lung cancer, for both squamous and non-squamous histologies, the majority of cases do express this target. By contrast, lung cancers with neuroendocrine differentiation tend not to. So I think that's important when we think about what populations we consider for this target.
So a drug again here, DS-1062. It's a very novel TROP2 targeting ADCs, and we have some clinical trial data for this. Can you summarize what you see on the slides and what you know about the study for us?
Yeah. So I think that the safety data looks comparable to what we've seen in other studies. Just a reminder to the audience that serious adverse event is a general term. That might mean someone wound up in the hospital, might mean that their hospitalization was prolonged. It doesn't necessarily mean it was high grade, so it's a separate consideration. The dose that was studied got relatively high for an antibody drug conjugate. Usually we see recommended phase 2 doses around 3 milligrams per kilogram. And the partial response rate of 25%, I would have loved to see better, and whether this just reflects the nature of the target or the expression level of the target in those patients, I think it's a little bit early to know.
Okay. Here's on the next slide another one, sacituzumab govitecan is another ADC, again targeting TROP2 in metastatic setting. And I think this one, we have another 54 patient level data. And to me, the data looks fairly similar, although I was wondering if you have any other comments looking at this one compared to the last study.
Yeah, well, again, I think TROP2 is an earlier and at least right now a little bit more of a challenging biomarker than MET and HER2 in lung cancer. I think we just understand its role as a potential target a little bit less, and the best way to identify populations that are most likely to benefit from these treatments is still a challenge.
It is. And we have an interesting waterfall plot for this drug on the next slide, which again suggests that the drug can be active, but it goes back to the comment you made about how do you identify the right patients. So I wonder if I can ask you and Kira at this point to summarize, if you will, your key sort of takeaway points in terms of the role of ADCs in non-small cell lung cancer. And because we do have a question about how far off these are, and I think what the question is meant is how far off these drugs to be available in a clinical setting. I think many of these are still in phase 1-2, as you can see here. I think we still need a little bit more data for them to be available on a routine clinical practice. But let's start with you, David, since you're on already. What are your takeaways about ADCs in non-small cell lung cancer?
Yeah, so Haas, I think they're just another arrow to add to our quiver. We have to remember that still most of our patients don't necessarily have an EGFR mutation or an ALK rearrangement. And most of our patients who get immune checkpoint inhibitors eventually progress. So to be able to offer them something else, even if the progression-free survival is 5 months or 6 months, that's 5 months or 6 months that they might not have had otherwise. So it's not replacing anything that I would have used for people, but it's nice to know that it'll be there.
Great. Keda?
Yes, it's a new treatment strategy that overcomes the limitations of traditional chemotherapy and targeted agents in a precision manner, because we need some kind of a target to use. And we have seen very promising results with trastuzumab deruxtecan in patients with HER2 mutations. So I think this could be important in the near future.
Yeah, and perhaps one thing that I can add for those of you who have patients who might be candidates for any of these clinical trials, if you can, contacting your local academic centers or places where they do trials, I think we would all appreciate having patients enroll in these studies to see if we can prove the clinical efficacy of these drugs. So participation in clinical trials and actually referring your patients to places where they do trials with these agents, I think would be immensely helpful and for the development of these drugs for everyone to have access to. So thank you, and we'll move on from this section. I think we're going to move a little bit out of the targeted therapies and what we've been talking about in terms of clinical trial and move into cancer care during COVID-19. Obviously, this pandemic has affected all of us. Everything that we do, from our personal lives to interactions with our own parents and grandparents and to our patients, have changed. This has been one of those sort of earth-shaking events that I really never anticipated having to encounter in my career. I just thought that somehow we were beyond these sorts of pandemics and events. But unfortunately, nature has another thought and has a way of coming out and sort of bringing a new challenge for us. I think to put the pandemic in a little bit of a context, we should start with a case just to exemplify what we're talking about. So the case we have for you shown on the next slide, I'm going to ask David to comment a little bit about it. As meeting Frank is 63 years old. He's got mesothelioma. He's received cis and PAM pre-op for his mesothelioma. Excellent response. As you see, the dates are December 19th through February 2020. Has offered surgery in March, but he chose to delay surgery because of COVID and because of concerns that many of our patients have. He returns to clinic in August with imaging that shows, unfortunately, significant growth in the tumor, and now the disease is no longer considered resectable. chemo is started with the hope to, again, see if we can get a response. David, have you encountered anything like this in your practice?
I have. This is actually our patient that we treated here in Dallas at UT Southwestern. And if you go to the next slide, you'll see the actual scans. So I realize with mesothelioma, sometimes it's a little bit more difficult. But if you look on that left scan for December, there's a fair amount of pleural abnormality and even some parenchymal nodules, and just an excellent response that makes this patient a candidate for surgical resection. And, it's not nothing to discuss surgery with a patient during a pandemic, but we felt that we had procedures in place to minimize risk, and we did feel that mesothelioma was a high enough risk disease. I think it was tragic for two reasons. Not only did this patient decide not to have surgery, but he was just lost to follow-up. So really 5 months go by before he touches base again with the clinical system, and you can see what the scan shows. And in retrospect, I'm not gonna blame the patient. I mean, this is really scary, but it's a reminder that this is really nuanced, and there are some diseases where we're going to have to keep doing what we need to, despite the risks of the pandemic.
Couldn't agree more. I think we all have seen numbers about the rates of mammography and screening colonoscopies going down. There is some data, and again, I'm not sure how validated it is right now, but there is data out there that at least in the state of Pennsylvania where I live, there's been roughly 45% decrease in a number of lung cancer diagnoses just during the pandemic. So this definitely is impacting us. I think our thoracic or lung cancer screening program started seeing lower numbers. So it is an issue that we need to discuss and pay attention to. I often tell my patients, right now we try to make at least Fox Chase one of the safest places we can. We screen everybody, any kind of symptoms, we isolate patients, we do testing, but I can understand the concern about coming in and being exposed to a virus that could have devastating effects. On our next slide, we have some guidance, actually. So FDA has come up with guidance, and I think, David, similarly, other organizations such as the NCI and ASCO have issued basic guidelines as to how to manage trials during the pandemic. We're going to get to Keta a little bit later to get the European view of all of this, because I think they sort of went through the first wave sooner than what we did. But David, we also have a question about how do we manage this in underserved areas? We already know there's a significant disparity in cancer care that's delivered. But as the question that just came in suggests, this is a real issue that all of us are dealing with. So I know, again, it's a lot of different questions in there, but let's start with the guidance that we have from ASCO and FDA and all of that. And then let's talk a little bit about how do we make this a little bit more even for everybody?
Yeah, so Haas, these are great points. And if everyone looks at the second to last bullet point, this is what the FDA basically came out with. They said, look, COVID is making everything really hard. We still think clinical research is important, but we got to do it in a safe and logical way. So do video visits, delay some assessments if you have to, do some labs near the patient's home, or maybe even find another place for treatment. Now, what does this mean for underserved patients? Well, so if transportation is more difficult for underserved patients on a clinical trial, then maybe allowing video visits makes it relatively easier for them. But is broadband internet access also less likely in an underserved area? Well, that's much less true with the advent of smartphones and other portable devices than it used to be. But as we think about assisting our patients who are medically underserved with clinical trials or routine clinical care, I think having reliable internet access is more important than ever. I think another important thing to know about this FDA guidance, which keeps getting updated every few months, is that it technically only remains in place while the federal government says we're having a public health emergency because of COVID-19. After that, Cinderella's carriage turns back into a pumpkin, and we go back to the ways we used to do clinical research, although we're starting to get feedback from the FDA that maybe this will last longer. And there are aspects from the NIH, like the Central IRB and CTEP, that are saying, look, you can also think about doing remote informed consent with a telehealth, We're shipping oral therapy to patients on studies that have oral study therapies. I personally think we should have been doing some of these things years ago, but it took a global pandemic to get us to the point that we're now doing it routinely.
Yeah, and then on the next slide, we have the ASCO guidelines, which are very similar to what we had seen on the other couple of slides. Again, I don't think we have a solution to how best deliver care for underserved patients. I think it is something that more and more we're dealing with for cancer centers that are in urban areas like mine in Philadelphia. And both transportation, as you mentioned, access to high-speed internet are major issues, and it does limit what we can do. Unfortunately, I think this is an area where advocacy comes into place. Patients who need care, it's hard to get to them in some of these areas. And again, I don't claim to have the solution as to how to manage this, but it is something that I think collectively as a community of oncologists, we're sort of obligated to put our heads together and come up with a solution to some of these problems. We cannot abandon patients just because they don't have access to internet and they don't have transportation. There has to be a better way of getting them involved and caring for these patients. But what that is could take many different forms in many different states. And geographically, you have to decide what works for your patient population and use a lot of the local resources right now to manage this until we're out of this COVID pandemic. Kira, let me come back to you. Again, we know the first wave of COVID was very difficult, as is the second wave. But you guys in Europe went through this ahead of us. What was that experience like, and what do European guidelines look like as opposed to what we have in the US?
Yes, these are difficult times. As you mentioned, we are now in the second wave. I think we have learned a lot of things. Perhaps now we are better prepared. So we have some recommendations, not only from ESMO, but also from ASCO or ILCC about how to deal with the patients. We evaluate case by case and, discuss in a multidisciplinary way the risk and the benefit ratio of delaying the anti-cancer treatment. We have learned that we have to keep the oncology department COVID-free, the day hospital, the investigation area, all patients that are admitted in oncology. We have now the possibility to perform PCR for COVID to all the patients. And also, I think communication is important. And now we have this kind of virtual meetings to communicate with the patient, with our colleagues. So we discuss a lot in our institution. I think, to keep the clinical trials open, it's important if we agree with the sponsor. So we have to discuss with the sponsor. It's clear that we have to guarantee the safety of the patients and also the compliance with the protocol. But we have, for example, implemented, if the sponsor agrees, some, for example, remote monitoring visits or even site initiation visits that are doing remotely by virtual tools. So I think, we have probably a better communication tools with the pandemic. No, we have today these kind of sessions, and I think this is something that we have learned, this and telemedicine for a number of patients.
Did you actually shut down your clinical trial office? On the next slide, we have some data on that, and I want to ask David to comment about also. But did you actually have to shut down your clinical trial unit?
No, we discussed, even during the first wave, we discussed with each sponsor the situation. And we discussed the possibility to include or not patient. And we guaranteed that the oncology department was COVID-free. And also we had some kind of strategies to trying to include patients even in that time, if the sponsor agreed with the situation.
Sure, yeah. David, any comments? Was your experience pretty much similar in terms of clinical trial?
Yeah, we actually did close our operations to new enrollment for about 4 weeks, from mid-March to mid-April. It was unclear how we were going to be staffing, and there were so many changes happening in North Texas at that time. We then reopened in a phased fashion, starting in mid-April, and by early June, almost all of our therapeutic trials were reopened. In recent months, our enrollment to cancer clinical trials here has been comparable to pre-COVID levels, but I will tell you that things are getting really bad again in Texas, and so I don't know if that'll be true next month or not. We're obviously prioritizing those trials that we think are going to provide the greatest benefit to a patient if we do have to make a choice. The bottom half of this slide is just some of our early published data where we surveyed the clinical research professionals like coordinators, nurses, data specialists, and managers in our center and asked them, do you think we should continue these adjustments after COVID-19 ends? Whether that's remote consent, telehealth, offsite diagnostics, and whether you defined experience in the respondent by whether they'd been personally involved in one of those changes or whether they'd been in the field of clinical research for longer, the more experienced someone was, the more likely they were to want to see this continue. And that to me was really striking. Made me think that these things actually are good. And so the people who have experienced it professionally recommend continuing to do it. And the people who've worked in the field longer have had enough time to be frustrated by how cumbersome and stringent clinical research has gotten. And they've been able to get the confidence needed to say, let's make a long-lasting change.
Hopefully something good will come out of all of this.
That's right.
Have 10 minutes. Yeah, we only have 10 minutes left, so I'm going to ask you guys to briefly comment about the rest of the slides that we have. On the next slide, there's an interesting study done mostly in academic centers, basically asking physicians how they have changed their practices. Keta, any comments on this? Has this been the way you have practiced? Also, your colleagues have changed their practices in terms of whether they offer more chemo, less chemo, immunotherapy, targeted therapy. What has been the impact for you guys?
Oh, yes, COVID has changed the way that we are treating some situations. So yes, this is a survey, but I have the same experience. So it's true that we have increased the use of GCSF, and perhaps during the first wave, we have also discussed what was the role of third line or fourth line of therapies in patients with lung cancer. So yeah, and also the use of telemedicine. No, yes, we agree that this has been changed during this pandemic.
Yeah. So Travolt is another study, and again, in full disclosure, we participate in this database also. And again, David, I wonder if you have any comments about the limited data we have so far from this. And also in your discussions, and Keta, this can come back to you also, if a patient of yours on active treatment is diagnosed with COVID, do you stop all treatment? That's a question we have from the audience. And I wonder what your comments are. Go ahead,
well, so if someone is diagnosed with COVID, do I stop all treatment? I have actually not had that question come up. I have had patients who are on treatment hiatus for another reason and have had COVID. I do have a patient whose husband, I just found out about an hour ago, is COVID positive. Mm-hmm. And I'm actually having her stay away from the medical center for the next 3 weeks. She's been on the same regimen, controlling her cancer for more than a year. So I feel very comfortable delaying these assessments. So I think I might answer differently if it were a more acute scenario. I do think the TerraVolt data is very informative, but it's very early. I am hoping that, when we see larger data sets, that a third of lung cancer patients diagnosed, hospitalized for COVID aren't dying in the future. I think our threshold for hospitalization may be different. There may be more centers. We may be better at treating it. But the other thing I want to draw everyone's attention to is the smoking, right? So look at what active smoking does to your outcomes. It's the same thing when we do thoracic surgery on someone who's an active smoker, or we do 6 weeks of thoracic radiation. If you're actively smoking and you've got another insult happening to your chest, you're in trouble. So if there's anything that we should be encouraging our patients to do, if not for another reason, is get off the cigarettes right now.
Good. Good opportunity to have that message come across. Keta, again, in the interest of time, the next couple of slides talk a little bit about ESMO guidelines. And again, just so that we have a European outlook also, can you briefly comment about what we see in the next couple of slides here?
Yes, on some recommendations for patients with stage 1 or 2 during the first wave. So surgery was not performed. So some patients received neoadjuvant chemotherapy. Also, we discussed the role of adjuvant chemotherapy, perhaps for those patients with N0 disease, those patients with tumors more than 4 centimeters, but N0 disease. We use more the GCSF. For patients with stage 3, we try to give durvalumab consolidation, and also we consider to modify the interval in the immunotherapy strategy. So we use longer intervals in our patients. In general, for those patients treated with targeted agents, we keep the treatment going. So these are more or less some of the recommendations.
How about telemedicine? How often are you using telemedicine now?
Yeah, we're using telemedicine, but probably for a group of patients, these patients that we have in the follow-up, these patients that have controls, and we are able to see the CT images, and there are no clear signs of progression. These are the patients that we are doing telemedicine. I have to say that probably in Europe, but for sure in Spain, we have worked more in telemedicine. So, yeah.
It's just not the same. I got to admit, I don't like telemedicine, honestly. It does work, and it's some of our patients really like it, and I agree with you, for follow-up is good, but I really don't like to do new patient visits by telemedicine. It is just different. We're coming to the close of the program here, both David and Kera. So first of all, thank you again for all your thoughts. Any final comments about COVID and how it has impacted your care? Again, take 30 seconds per person. Give us your final thoughts. Kera, since you're on, tell me what you think.
No, yeah, we have to face with this situation. So I think we have to keep the clinical trials open if possible, and the investigation. And we have to learn what we have done with in a bad way in the first wave, and to improve this situation. So we have to work together in this way. And more communication. Probably communication is the most important, with the patient, with the professionals, with the sponsors, with everybody.
Sure. David?
Yeah, Haas, I'd say that we all have to be really humble. We've never seen anything like this virus. And as someone who had a 36-year-old friend die from COVID last month,
I'm sorry.
I every time I make a decision for a patient, I think to myself, do I absolutely have to do it? And do I need to do it in that way?
Yeah.
I do.
That is difficult. I'm sorry you had to go through that. Sorry for everybody who's listening who has had to go through all of this. So I'm going to move on now, and we go into what we call SMART goals. As you see on the slide, SMART stands for specific, measurable, attainable, relevant, and timely. What we've talked about is that we have to apply predictive biomarkers to determine appropriate treatment for the appropriate patient in non-small cell lung cancer. Using liquid biopsies and NGS for molecular diagnosis is important. Evaluating complexities, challenges, and the potential promise of ADCs for non-small cell lung cancer has been explained or discussed in this program, and modifying our treatment plans to deliver cancer care during COVID-19 pandemic. There is no one-size-fits-all. It's different for different practice and different geography. We all understand that there are disparities, and it is something that I think we're going to have to pay attention to a lot more going forward. And hopefully we can be a little bit more even-handed. David, any, again, 30-second comment about any of this?
No, I think all of these are relevant points, and I think the audience is really right on in terms of identifying what are the key questions. Those queries that you've gone over are a lot of the unanswered issues in thoracic oncology right now.
Yeah. Kera?
No, perhaps from the European perspective, we need to work to have NGS available for all the patients, not only in tumor, but also liquid biopsy, and also to ensure the possibility to treat the patients with available treatment options, or, as you mentioned, in clinical trials. So that's important.
Great. So there are 2 or 3 questions and a couple of comments about the program. Thank you for those of you who like the program. We appreciate positive feedback. Also, we'll welcome negative feedback so we can improve the program. If you have any questions, please use the Ask Question tab. But a couple of specific ones. One is if a patient had no response to checkpoint inhibitors, would you try an ADC or enroll them on a trial? My answer is a definitive enroll on clinical trials to learn more. I don't know if David or Keta, you have any other comments?
Yeah, I think it's a separate therapeutic issue.
Yeah,
I do. Benefit from an immune checkpoint inhibitor, as far as I can tell, maybe that is some way prognostic, but I think it's a different mechanism and pathway.
Yeah, and then one last question we can get to. Actually, I can comment on two. One, there is no quality of life study that I'm aware of for the ADCs that we have talked about yet, but hopefully that will be coming. And the second was, none of us are surgeons, but there's a question whether there are surgical guidelines regarding the timing and how many lymph nodes to be examined and discussed and removed during the COVID. I don't think there is any necessarily recommendations for that, right?
Yeah, I think American Thoracic Society may have put out COVID guidelines that address screening, nodule workup, and surgery, but I actually haven't gone through them.
Yeah. All right. Thanks. So everyone, thank you for joining us to receive your CMEC credit for today's program. Please complete the post test on your screen, then click on the Request Credit tab to complete the evaluation and print or download your certificate. As a reminder, if you'd like to claim this activity as a CME for MIPS improvement activity, follow the steps described on this particular slide. Again, I'd like to thank you, Keta and David, for a wonderful discussion. It's been very helpful. Thank you, our audience, and for all the great questions that you sent in. We hope that you'll be able to use the discussion on molecular markers and emerging therapies in non-small cell lung cancer, treating lung cancer patients during COVID-19 pandemic. All of these are very hot button issues and important and ongoing. If any of your colleagues missed today's programs, will be archived at cmeoutfitters.com, along with other resources such as the animation that you may find useful.